Hello, everyone. My name is Dr. Ferghal Armstrong, and welcome to Cracking Addiction. And we have with us addiction psychiatrist, Dr. Manu Bhatnagar. Hello, Manu. I thought we'd explore, following from our previous discussion about drug-induced psychosis and the difference between that and schizophrenia and mood disorders. I thought we'd explore how psychosis might appear in the context of withdrawal treatment or in the context of withdrawing from stimulants, for instance. What's your experience of this?
Tricky. It's a multifaceted.
Hence my question.
Look, having the benefit of working in a tertiary hospital, a lot of the time when I see this means that it's not just me making up my mind after half an hour. I get to rely on a lot of skerricks of information over 24 hours and see what's happening across a few days often as well. And that's where you can figure out the overall course of the psychotic experience, psychotic episode. Methamphetamine withdrawal is complicated by any means. You get a very myriad of mental health symptoms over a period of about 2 weeks. And part of that can be psychosis, purely the withdrawal. But the challenging part is when someone is experiencing psychotic symptoms to the same intensity for the entire amount of time, and knowing how much of that is causative from the drug versus has the drug flipped a switch, like we said last time, and precipitated a psychotic episode that's going to go on for a while. Obviously, it's not expected that someone stays in hospital the entire time, and treatment is a bit different, but there are some underlying principles between how to treat a psychotic episode caused by drugs and schizophrenia. Now,
let's go into that. The standard treatment for someone coming in for a detox off methamphetamine, for instance, we would use benzodiazepines in moderate doses around about 40 milligrams, 40 milligrams a day. If they were psychotic, would you then use benzodiazepines perhaps in even greater doses for the sedative effect, or would you leap in immediately to antipsychotics?
Yeah, look, I think a lot of people would assume that if someone is psychotic, the first-line treatment, immediate treatment is antipsychotic. Just by the language that we use, that makes sense. But if you really think about it, antipsychotics tend to take 4 to 6 weeks to have an actual antipsychotic effect. So if we found this upon the dopamine theory, which is probably the best theory we have right now, but talk to me again in 50 years and we might reconsider it. The idea of psychosis is that you have a surplus of dopamine flowing to two particular parts of the brain. Now, that's incredibly simplified, and I'm sure there's a lot of neuroanatomy that even I just don't understand at the moment to explain it. But if stimulants cause an overproduction of transmission of dopamine in those areas, antipsychotics are dopamine blockers. So they block dopamine, not just in those two areas, everywhere, but that's, because we're not very good at selectively blocking dopamine. But nonetheless, that is a paradigm in schizophrenia that we use at the moment, and that's a paradigm that has led us to deinstitutionalize, get people out of insane asylums and get them back into the community. And all the research that's happening in schizophrenia is to see specifically what's going on in different parts of the brain, but antipsychotics work, and they have allowed a lot of people to have a lot of quality of life. So if we hone in on what stimulant drugs and other substances are doing, the reason you get high and the reason they make you happy is because they flood your brain with dopamine and give that reward pathway a lot of juice to be happy. So just by that token, you could assume that blocking dopamine has some benefits, but antipsychotics tend not to work that way. The reason it takes so long is because you're setting up constant negative feedback loops to regulate the amount of dopamine in particular parts of the brain. Yeah. That means talking to neurons and slowly making changes. Just the same way most psychotropics work is by establishing harmony with certain neurotransmitters. The thing is, antipsychotics aren't just about dopamine. So there are some antipsychotics that just block dopamine and not very good for a lot of people. They can cause a lot of side effects by blocking dopamine everywhere. The antipsychotics we use initially, they're also very sedating and they are good for agitation. So that's where they might be beneficial. But I do agree with you, Ferghal, and that's why we do the things that we do in detox units and for acute agitation. We use benzodiazepines to control agitation and minimize the amount of arousal that someone is experiencing in an episode of, call it psychosis or withdrawal or even delirium, which can occur after a lengthy period of hazardous drug use. So,
yeah, there are two camps, though, aren't there? There is the camp that suggests that really you should just be relying on the sedative effect of benzos, whereas the other camp suggests that you should be relying on the sedative effect or the early sedative effect of antipsychotics, pending the antipsychotic effect, because it's very difficult to then tease out, is this a first episode psychosis or is this a drug-induced psychosis? What's your gut? I mean, what do you reach for? Everyone has a reflex reaction between their brain and the pen and the script pad.
Yep.
In the face of psychotic symptoms in the context of methamphetamine withdrawal, what do you actually do?
I think knowing that it's definitely in the context of methamphetamine withdrawal, drawing up a timeline and saying, when did you last use methamphetamine? Were you well? Were you bereft of psychotic symptoms prior to using that? If you can establish those two facts, then I think the idea of using benzodiazepines makes a lot more sense to me, because you're not dealing with someone who has an unremitting course of psychosis for weeks to months thereafter. The expected course of methamphetamine withdrawal is up to 2 weeks, and even after some psychotic symptoms can subside in 1 or 2 days, anxiety, agitation, restlessness still persist. And that's where benzodiazepines have an added benefit to antipsychotics.
So really, it goes back to that longitudinal assessment. I use the word longitudinal guardedly in the context of a 2 to 3 week admission, but for most withdrawal services, a 1 week admission for the management of stimulant withdrawal is appropriate.
Yeah.
So watching the patient and awaiting that expected resolution of psychotic symptoms within the context of the supportive environment of a withdrawal unit, plus using benzodiazepines, then from what I'm hearing, is an appropriate intervention. And if the patient persists in the manifestation of psychotic symptoms beyond 2 to 3 weeks, then that's the time to consider the primary psychotic syndrome, probably schizophrenia.
Yeah. And that's where your treatment will also change. So like I mentioned, a lot of the medications that are used in the initial phase of withdrawal and agitation are your conventional, typical, they're actually atypical antipsychotics, and they have more affinity not just to dopamine, but serotonin and histamine, which are very sedating chemical receptors. So tranquilization and agitation control, that's the game of the game in the first 2 weeks. Similar to benzodiazepines.
So that goes back to that goes back to the old classification of antipsychotics as major tranquilizers, as opposed to the benzos, which were classified as minor tranquilizers, doesn't it?
Yeah, I mean, there's a reason historically these names have existed, but we don't do that if someone has a first episode of psychosis. We don't use antipsychotics purely for the purpose of tranquilization if someone is young and naive and can hopefully still try and integrate into the world. So milder dopaminergic agonists are the first line nowadays. Great metabolic profile, and also some evidence that some of the negative symptoms can be nipped in the bud if you use them early enough.
So you're referring to the partial dopamine agonists, are you?
Yeah. So
aripiprazole, such as a drug, aripiprazole. Yeah.
So people with schizophrenia, on average, have a 20-year life expectancy that's below the general population, and part of that's the illness, but the other part is the medications that we have used for the last 30 years to treat schizophrenia are really notorious in metabolic syndrome and diabetes and heart problems. So the new trend is to use medications that don't have metabolic syndrome, and not only can they be well tolerated, but they can also prevent the idea of treatment-resistant schizophrenia.
Really, it's important to establish, the de novo development of psychotic symptoms in the context of substance use, to then make a diagnosis of drug-induced psychosis, or more correctly, substance-induced psychotic disorder, to then try and just rely on benzodiazepines and await the resolution of symptoms, but then have an open mind about the potential persistence of psychotic symptoms, and then explore the role of antipsychotic therapy going forward in the context of a diagnosis of actually a first episode psychosis.
That's right. And in that grey area, in that time frame where you don't know which one's which, that's why this phrase first episode psychosis has come up. So most mental health services will have a team dedicated to first episode psychosis. But if you look at any textbook, the DSM and the ICD, they don't have a code for first episode psychosis. So it's this vague, deliberately vague term that we've devised to say this is a holding area for people who may or may not end up having schizophrenia. But the other really important thing to know about schizophrenia, a big prognostic factor about long-term recovery rates, is time to treatment. So the period of untreated time when you clearly have symptoms of schizophrenia, for some people that's luckily days, for some people it's months. If we're going to the territory of a year, your likelihood of having inter-episodic positive symptoms really shoots up. So this is where we sort of go, is this first episode psychosis, and should we be starting regular antipsychotic treatment even though we don't know for sure which way this is going to pan out? So it's a controversial area, and even between health services there's a bit of debate about which way to go, but we do know that not treating someone when they're clearly debilitated by psychotic symptoms can have its own harms.
Yeah, so there's a tension, isn't there, between those who want to watch and wait and those who want to get stuck in, even within the context of one admission for one withdrawal admission.
Yeah, and I think fundamentally the most important thing in the middle of all this is the patient and their expression of their preferences with which medication, which treatment they want, and allowing them to have the right amount of supports from a psychosocial point of view to limit all the other modifiable dynamic risk factors of psychosis, mainly the most important one being an abstinence-based policy. There is no safe level of stimulant use. If you've had a psychotic episode once, you just cannot endorse any amount of safe use.
And also, I think it's important in that context to emphasize that the route of administration of the illicit stimulant does not in any way influence the positive, and it doesn't help with harm reduction. So the risks of psychosis and ongoing psychosis are the same with injected methamphetamine versus smoked methamphetamine. It doesn't matter how you ingest the drug; it's all bad.
Yeah, definitely. At the end of the day, neurochemically, it's all going up there. So
it's all going up there.
Yeah, it doesn't make a difference.
Mm-hmm. So again, the consideration of the treatment for first episode psychosis also, all of those psychosocial interventions, the wraparound services, the non-drug treatments, they're absolutely crucial for prognosis and improved functioning. But it's also absolutely crucial in the context of abstinence in drug-induced psychosis. I think it's really important for us to not downplay the fact that ongoing care into the future, it's not predicated on the medication. It's predicated on the medication playing a small part in an overall service.
Absolutely. And I think the best amount of medication is the least effective dose. So if we can, my role as often as an addiction psychiatrist is to say, how much support can we put around you so I can bring this dose down to a level where it's causing the least amount of side effects, but it's just enough to prevent the next episode happening. And having supports and carers and having functional supports is vital.
And I suppose my role is also to think about what kind of supports I can put in place to help people achieve and maintain abstinence. Because really, withdrawal medicine is the smallest step in the longest journey. So my role as an addiction doctor is really the least significant part in someone's overall recovery journey. So a lot of people think, withdrawal is the be all and end all. It's complicated and it can be tricky at times, but really it's only, if it really is just a drug-induced psychosis, it's only maybe 1 to 2 weeks of an inpatient stay, followed by a recovery journey of abstinence and engagement with community and psychosocial supports and relationships with other people.
Yeah. And something that's, I heard in one of your earlier podcasts about dual diagnosis and methamphetamine use is that people who have schizophrenia or have a major mental illness are 2 or 3 times more likely to use substances. So that bidirectional nature of psychosis and substance use is really vital, because if someone has those neurocognitive deficits that come with schizophrenia and they are using substances, some of the tenets that we use in the withdrawal unit about which stage of change they're in, and all those kind of things are sometimes not applicable to everyone. And you still need to see how much can I provide this person outside of the withdrawal management when they go home, because they're going to need an equitable amount of advocacy and resources to someone who has a lot of their own functioning and autonomy behind them.
Yeah. Manu, I want to thank you again for your expertise. It's been a great discussion, and I really hope that we can speak again very soon. Thank you.
It's good to be here again, Ferghal. See you soon.
That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.